Hello and welcome. Today we're diving into a rare but fascinating condition that affects the urinary system, Liddle syndrome. This genetic disorder can cause high blood pressure and low potassium levels, and while it's uncommon, understanding it is crucial for proper diagnosis and management. Liddle syndrome is caused by genetic mutations. These mutations occur in specific genes, primarily the SCNN1, SCN1B, and SCN1 genes. These genes provide instructions for making subunits of a protein called the epithelial sodium channel, or ENaC. These channels are found in the cells lining the distal nephron, the last part of the kidney's filtering system. These mutations typically arise spontaneously or are inherited in an autosomal dominant pattern, meaning only one copy of the mutated gene is needed to cause the condition. So, if one parent has Liddle syndrome, there's a 50% chance their child will inherit it. Now, let's get into the nitty-gritty of how Liddle syndrome messes with your body. The mutated ENaC proteins in Liddle syndrome become overly active. Think of them as doors that are stuck wide open, allowing too much sodium to be reabsorbed back into the bloodstream from the urine. When sodium is reabsorbed, water follows. This increased sodium and water retention leads to an increase in blood volume, driving up blood pressure. Simultaneously, the kidneys try to maintain electrolyte balance by excreting more potassium in the urine. This potassium loss results in hypokalemia, or low potassium levels in the blood. The renin-angiotensin-aldosterone system, which normally regulates blood pressure and electrolyte balance, is suppressed in Liddle syndrome because the kidneys are acting like they are being exposed to high levels of aldosterone even when that isn't happening. Liddle syndrome is a rare condition, and precise epidemiological data is limited. It's believed to affect a very small number of people worldwide, but because it's often misdiagnosed or goes undiagnosed entirely, the true prevalence may be underestimated. It can affect individuals of any ethnicity. However, due to its genetic nature, certain families may have a higher incidence. The signs and symptoms of Liddle syndrome can vary in severity. The most common symptoms include high blood pressure, often starting at a young age or even in childhood, and low potassium levels in the blood. Individuals may also experience muscle weakness, fatigue, headaches, and excessive thirst or urination. Because these symptoms can be attributed to other more common conditions, it's crucial to consider Liddle syndrome, especially in cases of early-onset hypertension unresponsive to typical treatments. Diagnosing Liddle syndrome can be tricky. The first step is often recognizing the constellation of symptoms: high blood pressure, low potassium, and a family history suggestive of the condition. A key diagnostic clue is low renin and aldosterone levels. Blood and urine tests are used to measure sodium, potassium, renin, and aldosterone levels. Genetic testing to identify mutations in the SCNN1A, SCN1, or CNG genes is the definitive diagnostic test, confirming the presence of the genetic defect. Ambulatory blood pressure monitoring may also be helpful to assess the severity of hypertension. Liddle syndrome does not have official classifications or subtypes based on the specific gene mutation. The clinical presentation is largely consistent across individuals with different mutations in the SCNN1A, CN1B, or CN1G genes. Unfortunately, there's no cure for Liddle syndrome, but it can be effectively managed. Treatment focuses on controlling blood pressure and restoring potassium levels. Dietary sodium restriction is crucial, as reducing sodium intake helps to lower blood volume and pressure. Potassium-sparing diuretics, such as amiloride or triamterene, are the cornerstone of treatment. These medications block the ENaC channels in the kidney, preventing excessive sodium reabsorption and potassium loss. Regular monitoring of blood pressure and potassium levels is essential to adjust medication dosages as needed. Angiotensin-converting enzyme ACE inhibitors or angiotensin receptor blockers ARBs, often used to treat hypertension, are typically ineffective in Liddle syndrome. Because Liddle syndrome is a genetic condition, there's no way to truly prevent it. Genetic counseling is recommended for families with a history of Liddle syndrome who are considering having children. This counseling can help them understand the risk of passing on the mutated gene and explore their reproductive options. With proper diagnosis and management, the prognosis for individuals with Liddle syndrome is generally good. Adherence to dietary sodium restriction and medication regimens is key to controlling blood pressure and preventing complications such as heart disease, stroke, and kidney damage. Recent research has focused on developing more targeted therapies that specifically address the hyperactivity of the ENaC channels. This research holds promise for improving the long-term management of Liddle syndrome and minimizing the need for lifelong medication. Scientists are also working on improving genetic testing methods to diagnose the disease earlier.